leadership from four groups that have a great interest in the problem we've been discussing. First, I'd like to welcome Dr. Bobby Mukkamala, who is a head and neck surgeon who has served with the American Medical Association Board of Trustees for the last couple of years. He practices in Flint, Michigan, and is a past recipient of the AMA Foundation's Excellence in Medicine Leadership Award. Doctor, thank you for being here. Doctor, would you begin?
Good afternoon, Chairman Doggett, Ranking Member Nunez, and members of the subcommittee. Again, my name is Dr. Bobby Mukkamala. I'm a board-certified otolaryngologist, head and neck surgeon in private practice in Flint, Michigan, and a member of the American Medical Association's Board of Trustees. On behalf of the AMA, it is an honor to provide testimony on the important issue of unanticipated out-of-network care, often referred to as surprise billing. I very much appreciate your willingness to explore solutions to this problem that has significant consequences for our patients. The AMA has long been concerned about gaps in out-of-network coverage and is committed to working on solutions to protect patients from the financial impact of surprise coverage gaps. The AMA believes that workable solutions can come in many forms, but the best solutions have several common principles at their core. First, protection for patients. Patients should be kept out of the middle of payment negotiations. In situations where patients do not have the opportunity to select an in-network provider, they should not be charged any more than the in-network amount, and payments should count towards their deductibles. Second, network adequacy must be regulated. Critical to any surprise billing solution is a focus on increasing the adequacy of provider networks. Third, we must establish fair payment for providers. To ensure that appropriate market incentives remain in place, any solution must incorporate a mechanism to ensure fair payment to providers. Such mechanisms could include a minimum payment standard based on physicians' rates and/or a billing arbitration process that requires the consideration of many factors. Finally, transparency in many forms is important. For example, all patients who knowingly choose to obtain scheduled healthcare services from out-of-network physicians should be informed about their anticipated out-of-pocket costs. Regarding network adequacy, it is important to recognize that physicians very much want to be included in health plan networks, but they want to be offered fair contracts. However, with nearly 57% of physicians in practices of 10 or fewer physicians, and with most health insurance markets highly concentrated, many physicians are in a weak position relative to commercial health insurers. Insurers need to be incentivized to offer fair contracts to physicians, and we recommend that Congress facilitate this through the regulation of provider networks. To protect patients, network adequacy standards should include measurable requirements on the front end before insurance products are brought to market, and factor in minimum time and distance requirements, maximum patient-to-provider ratios, and maximum wait times. Regarding the fair payment of out-of-network services, the AMA urges Congress to avoid any solutions that set minimum payment standards for out-of-network care at non-competitive rates. Any guidelines on out-of-network provider payment should reflect actual charge data for the same service in the same geographic area. Proposals that use in-network rates as a benchmark for provider payment should be avoided. These rates are negotiated by physicians and plans during the contracting process, and fees are discounted in exchange for contracted benefits. Those companies that don't sit down to negotiate should not benefit from skipping that step. Setting payments at these discounted rates would further disrupt the increasing market imbalance favoring health insurers. It's likely health plans would quickly drop physicians from their networks, knowing they could use our services for less when we are outside of their network. Additionally, payment benchmarks should not be based on a percentage of Medicare rates, which simply do not reflect the costs of providing care. When you adjust for inflation and practice costs, Medicare physician payment has declined 19% over the past 17 years. As such, linking out-of-network rates to Medicare would eliminate any incentive for insurers to build adequate networks or offer physicians fair contracts. Finally, it is critical that any benchmark come from sources independent of interested parties. Manipulation of insurer-controlled data for these purposes has happened in the recent past, resulting in real harm to patients and physicians. In conclusion, the AMA looks forward to the opportunity to work with the committee to protect patients from unanticipated gaps in their coverage and to promote greater access to in-network care. Thank you very much.
Thank you, Doctor. Ms. Thornton?